Welcome to our explainer. Today, we aren't just memorizing facts about a drug. Nope, we are stepping right into the middle of the emergency department, and we're going to use our knowledge to save a patient's life.
All right, so let's get right to it. Meet Casey. He's 25, has type 1 diabetes, and his friends rushed him in. Why? Because, and I quote, he is acting funny. You and I know that can mean a million things, but for us, it means he's confused, has a headache, and his speech is slurred. This is our minute zero.
And things go downhill fast. Casey's initial glucose reading on the monitor just says low. It can't even give us a number. And then he becomes completely unresponsive. This is that moment where your training kicks in, your adrenaline starts pumping, and you have to start running through all the possibilities in your head.
Okay, so you have a patient with diabetes, altered mental status. Right away, two huge critical conditions should be flashing in your mind. Is this a hypoglycemic reaction, or is it diabetic ketoacidosis, DKA? And how in the world do we tell them apart when the clock is ticking?
Now this table right here, this is our clinical roadmap. Let's look at Casey's symptoms. The confusion, the headache, the slurred speech. It's like a textbook definition of a hypoglycemic reaction. We're not smelling that fruity breath or seeing the extreme thirst that screams DKA. You put that together with his low glucose reading and bam, the diagnosis is clear. This is insulin shock.
So, we've got our diagnosis locked in. Now, it's time to act. When you have severe insulin-induced hypoglycemia like this, there is one immediate, life-saving treatment we go to: Dextrose. Well, let's not overcomplicate it. Dextrose is glucose. It's the body's most basic fuel. By giving it intravenously, we're basically creating a superhighway for energy to go directly into the bloodstream. It totally bypasses the digestive system and makes a direct deposit to the cells, especially those brain cells that are literally starving.
But here's a key point. Not all dextrose is created equal. You know those lower concentrations? They're great for keeping someone hydrated. But for KC, who's unconscious, we need the heavy hitter. We need a high concentration formula like dextrose 50% to pull his blood sugar out of that nosedive, and fast. This isn't just about fluids. This is a full-on rescue therapy.
So how does this stuff work so incredibly fast? To really get that, we need to follow the journey of dextrose from the IV bag all the way to Casey's brain cells. And that journey, my friends, is called pharmacokinetics.
Pharmacokinetics is the story of what the body does to a drug. But for IV dextrose, that story is more like a single explosive chapter. Think of it as the body's emergency express lane for energy. Because when someone's life is on the line, every single second counts.
And this right here just lays it all out so perfectly. It's so effective in an emergency because we literally skipped the entire absorption phase. The drug doesn't have to be digested, it's just there. It's distributed immediately and put to work feeding those hungry cells right away.
Okay, let's talk dosing for a second, because this is super important for your clinical practice. A common adult dose is 1 50 milliliter ampule of D50W, right? That's 25 grams of dextrose. But, and this is critical, you never give that to a kid. For pediatric patients, the dosing is always based on weight, and you're going to use much lower concentrations, like D25W for children and D10W for infants. The take-home message is you absolutely must follow your institution's specific protocols. Today is all about understanding the why behind the drug.
Okay, Casey is starting to wake up. He's coming around, but our job is not done. Not even close. When you give a potent, high-concentration drug like dextrose 50%, you're also introducing a whole new set of risks that we have to stay on top of.
So what could possibly go wrong when we give dextrose through an IV? Well, we have to be super vigilant for problems, not just from the drug itself, but from the IV line too. It's all about solving one problem without accidentally creating a brand new one. So here's the deal. We have to watch our patient like a hawk. If we push this concentrated sugar in too fast, we can overshoot our goal and cause rebound hyperglycemia. Or we could cause dangerous fluid shifts in the body. And don't forget, D50 is really tough on the veins, so you have to keep a close eye on that IV site for any sign of trouble. All right, let's boil all this down into a practical checklist. What are the absolute must-do actions for you as a clinician when you're in this exact situation?
You see how this systematic approach covers all our bases? It ensures we're being both safe and effective. And then, once Casey is stable, alert, and oriented, our role shifts from rescuer to teacher.
You know, empowering the patient is every bit as important as the medicine we just gave them. We have to make sure Casey understands why this happened. Was it stress? Did he miss a meal? Teaching him how to prevent it is what keeps him out of our ER next time.
And now for one last crucial piece of information. This is one of those concepts that trips up so many students, but it's absolutely vital for understanding IV fluids. We're talking about a lower concentration here, D5W, but the principle behind it is a total game changer.
So why on earth does this matter? Well, think about it. You infuse D5W, and the body immediately metabolizes that dextrose, just eats it right up for energy. And what's left behind? Free water. That free water effectively makes the blood hypotonic, causing fluid to rush into the cells. Now for KC, that's not a huge deal, but for a patient with a head injury, it could be absolutely catastrophic. So here it is, the one thing to remember. What's in the bag is not always what happens in the body, and that really makes you wonder, doesn't it? What other common clinical assumptions might be worth a second look?